on the longest.
You thought I know all of them?
Just the one.
Whichever one you'd like.
And that's going to be the exact same one that's already been done 5 times. Or is it deeper? I'm interested in it. Who from here is on the MVP? That's 1,000% deeper than anything that they cover. I wonder if you could just call for that.
Hypothetically, we can. Really?
I go.
Really? Oh, I would be really interested in that. I think I just need to get myself organized.
I was just sitting in Starbucks with my laptop. I had my email on it.
Yeah.
I'm not ready. But I did the dots. Yeah. I'm not.
I was hoping you were. I don't know.
I'll forward you.
That would be awesome. Thank you. Not thinking about all this complicated stuff. Yeah.
I mean, I've always got. And it's like, I think it's hard too to figure out, like, do you just approve it and be like, okay, less than 2 weeks?
Right.
Yeah. We'll keep rolling, or is it like, is it here instead?
I know. I will. The latter is probably closer.
So it's just because.
No, 2
And
and
just
then 4.
Showing up where it matters and not.
Well, is there?
The name of the game.
Stop.
I'm sorry for not.
Oh, really?
Hi.
So, like, you
Good, how are you?
Not too bad.
Yeah.
So,
Oh.
So you.
I see.
Each
Okay.
person
I had my email on the
Yeah.
phone.
Oh, my goodness.
So,
No worries.
Yeah.
We did a little check-in on some other stuff and.
Okay.
We just sort of stuff like this.
Yeah. Need to cover some things.
Congratulations. Thank you very much. Let the work begin, right?
Oh, my gosh. 2 down, 7 to go.
7 to go. We've got a little bit of a template, we just got to make it work in that area. So, and we have more time.
I wish you'd tell our county commissioners that.
Yeah.
We have a template. We'll try and make it work in your region.
We have a nice template.
You know what's neat is I was thinking about this.
I rolled my eyes.
Infrastructure,
Allison knows why.
the infrastructure that we built, as far as planes and all that stuff, that's what we
Giggle, giggle.
Yeah.
Good.
How do you
I like your color choice
provide
today.
that?
I was just admiring your film.
It's 6 months. I got it in Uganda. 3.
Well, then it's.
Oh, well, that's.
Oh,
Oh,
I don't want to.
I mean, I think I got
Yeah,
that.
we were scrambling.
Is that a stone? Was that
for 3 months to get the thing.
Cool.
I don't remember where I got it.
Yeah.
Boutique. It was a boutique thing.
Well, then you're going to get.
Okay,
It sounds like.
okay, good.
Sounds like Pearson.
Yeah.
On their way.
Did you see
Well,
that
I'm
they
ready to
hired
meet my daughter.
Senator O'Ban to run the transition?
No, that is news. I did not know that. So,
I thought it was,
interesting.
I thought it was incredibly interesting.
That's beautiful.
I was texting with our lobbyist about it, and I said, I think this is good, because if your ability to pay your mortgage is tied to the fact that you have to have waiver funding to do this, that probably means the Senate is going to release that funding ultimately, right?
It's good to have that.
And he
that
said,
much
that's
insider.
probably a rational, what did he say? Something like, that's probably a rational understanding. And don't forget, this is politics or something.
Yeah.
I was like,
Yeah.
no, I need some rationality here.
Oh, that's pretty.
But I thought it was, I must have read the paragraph like 17 times, because I thought, you can't, there must be like 2, and then it says comma.
Yeah.
Well, that is interesting.
I don't know what, this guy was.
And that's who they would use, because somebody needs to kind of help.
Which,
In
my-
I am totally. It's really weird.
and he was like, so we're not going to be able to.
Don't get pushed out.
What the hell have you done?
Go with it, I know.
I'm like, wow. I'm like, hey, feel uncomfortable. the new
Was that-
thing. Trump says there's no ethics.
Three results, so
So,
three results.
Why not? Why not?
So that's where
Let's go for it.
Ohio, Mississippi, that's my hometown.
So do you feel like you're any closer here?
Cool. Yeah. How's it going? What do you want to do? Yeah.
So you're thinking of an app?
I feel like
That's right.
the campaign has barely begun, and that I,
Colorado Springs, Colorado.
Oh.
That eminent domain is just, it's a convenient little, yeah. Yesterday. Yeah. Yeah, they didn't, I was saying, you didn't get paid to be your, family scout. But yeah, no, it's that unfairness in the system.
Hey, how are you?
Yeah, that's how it would be, yeah, they just, we're gonna use the sport jam. We'll see you later. And you're still here, well, we gotta get plugged.
Oh,
Good, it's normal and good luck. Yeah, no, that's great. Yeah. Oh, Twitter's online, and I look forward to, when's that? Okay, I'm excited.
Yeah.
Relax, overall, okay, overall. Okay, so like, does it just, how do you cross that? Okay.
Oh, here.
Yeah. Okay. Both, oh, it's Spokane County or is it regional? I actually just messed up here. I'll talk about the network analysis. I got it. So you come over to this. No, it was fantastic. I'm a really big social psychology guy. So I'll see how these little bubbles, like these different organizations interact with each other, factors. I was really excited. So I look forward to working with you guys. Moving forward. Good to see you again. This is like 12 hours. I don't know how.
Sure it is, but you know,
Thanks.
we got back a little late last night. And yeah. Playing through some PowerPoint for our desktop.
Yes.
Presentation, so I'm like, all right. So I'm gonna do a little bit of housekeeping first, and then I'll introduce you. And then we talk about doing like big win or big win and ROI. And then it's back to me. Yay. I did the easy part. Yeah.
Good morning.
You give me the one.
Yes, it's health with a capital H.
Is it the Empire Guest or
Yeah.
the, okay.
No,
So,
Okay.
please select the smart can down and everything.
Here we have a couple feedback comments that, oh, I can't be there.
Summer.
It's hard. Yeah, I'm not going to get everybody there, but I'm glad to be able to come there.
Hi, how are you?
Good, how are you?
Good.
Actually, my husband
Oh, my God.
yeah, so 3 weeks ago. Hi.
Can you?
Absolutely.
Be a good one.
they brought us that drink.
I know.
So he's recovering well, I hope?
He is, you know, he's just so happy with allergy season. Not.
You know, I was. So you doing homework?
I'm Robin. Hey, Robin. Hi.
And
Yeah. Right.
I am from
My meeting in
Oasis, and I'm that's what I'm here for.
PhD or PhD? Yeah. I can. And what form of-
Gosh, I haven't seen you in 2 hours.
It's been a while.
I loved it. I really appreciate it. Here to help get
the information that we got.
Yeah, and the reading ahead of time, the second round is sober. Very complicated process.
Wonderful organization. That did it.
Pull the,
Have you been with it?
no, actually, I'm quite new. I started out
Education from
Can I get a confirmation from someone on the phone on whether or not you can hear us?
reading we had prior to the went into
But my background is
about
clear.
what European seminars really do as the government really done in terms of policy.
Probably
Yeah.
place.
Yeah, we're in a different place today, but they have lived
Here.
Hi all, can I get a check-in from someone on the phone on whether or not you can hear us in here?
I can hear you. This is Maureen.
Hey, Maureen.
This one, maybe still this spot. You can use the one up here.
Bye. Nice to meet you as well. Yeah.
Seems like,
So I guess meals are supposed to meal meals and
We do canvas.
Alrighty, hello all.
We do the entire.
Thank you for coming to yet another ACH Leadership Council meeting on this beautiful May day. We're excited to have you all here. A couple of housekeeping items before we get started. Once again, you guys are blowing my mind with attendance, and we are semi out of chairs. Go team. Feel free. We're going to be doing some small group discussions for the second half of the meeting, so we're going to be leaving these tables. Feel free to grab a chair and put it on the inside of the table if that's something that you're comfortable with, or sitting on the outside. I just want to remind you all that if you're sitting on the outside of the room and away from these tables, your voice will not be picked up by the microphone to go up to the people on the phone. So if you're outside and you want to participate in conversation, make sure you raise your hand so that I can bring a microphone to you. Second bit of housekeeping information, if you need the bathroom, it's right around the corner outside the glass doors and to your right. The Wi-Fi password is the Empire Guest Wi-Fi, and the password is capital H Health 20. And the last bit of housekeeping is that we are introducing a new little feedback form to accompany all of our Leadership Council meetings. So if you did not get this 2-page form that says community feedback loop on it, please check back in with Devin and grab that form. We absolutely recognize that we try to get through a lot of information at these meetings and sometimes don't have time to get to each question or comment, but really the point of these meetings is to hear feedback from the Leadership Council, so we want to make sure it's a little more institutionalized. We have made this form, and I have to give a shout out to Brian, who is the inspiration because he uses this form in another meeting. And for each section that we're going to be going through today, there are some questions on this form. And we would just ask that if you have a question that you would like us to address, and it doesn't get answered during the actual presentation, feel free to throw it on this form, and then we're going to start a public Q&A page on our website. After every leadership meeting, we'll post the answers and the questions to all of them. There's also a couple of discussion questions on here where we're looking for just sort of general feedback about what you think of the presentation or what your organization's role might be. There are places on this form where we've noted that we would attribute comments to your organization. So that's where we might say, there's a question that asks, what do you see your organization's role in our theory of alignment? And we would ask that you be aware that we're going to post this publicly with your organization. All of the questions that you ask will be anonymous, posted on the Q&A. So if you have any questions about that, feel free to ask me, but I would love feedback afterwards about how this feels and if it sort of helped the meeting flow. There's a big chunk of it that's all going to be reserved for small group discussion, and the prompts are on this page. Okay, with that, I know there's a couple people still settling down and grabbing coffee. Make yourself comfortable, but I ask you to keep the chit-chat to a minimum. And with that, I am ready to welcome Pam up to co-chair our meeting. Single chair today.
Okay, so my co-chair, Jack Davies, is actually doing a cross-country trip, driving across. I don't think I'd want to spend that much time in a car, but she sounds like she's having a blast, so.
The mic's off.
Yeah. It's mic off. Yeah.
It says it is.
Closer.
Might be.
Hello? There we go. The one request I would have is that as we go through the day, if you're having little side conversations, if you could make sure that the mic right in front of you is turned off, because the people that are on the phone pick up all of what you're saying, and while in the room it may be quiet, on the phone it will be really hard for folks to track. So just push the button in front of you if you're going to have a little side conversation. Welcome everybody. It's a great day outside. It's cooled off just a little bit, which I like. This Alaska girl melts when it gets over 80. We're going to do introductions, and as we do introductions, if we could just take maybe 30 seconds or so to talk about maybe a big win that you've had, or if you submitted a letter of interest recently to the call for letters of interest and you want to just tell us 30 seconds about what you're proposing, we'd love to hear that as well. I know that this isn't on the agenda, but yesterday the BHT and EHF boards took a little road trip and went to USC, to the Camas Center. And we did a joint board meeting there, and we had members of the Spokane, Colville, and Kalispell tribes do presentations to us around some of the work that they're doing. And I have to say, it was well worth the trip. I learned so much. Tony, you were there.
Fabulous. 2 thumbs up.
2 thumbs up. I just would say Jessica, who hosted us there, was amazingly graceful for all of us, intruding and doing tours. And if you have the chance to go and see that, it's 75,000 square foot, the Camas Center, and it's an amazing facility, so I would recommend it highly. Okay, so if we could start maybe this end of the table with introductions. Come here.
I'm Lilia, and I'm from Operation Healthy Family.
Use your outside voice.
Okay. I'm Lilia, and I'm from Operation Healthy Family.
Okay.
She was Lilia from Operation Health.
Okay.
I'm Brian from Empire Health Foundation. So quick win is we operate as an intermediary for a lot of our aging services program from a larger foundation. We were just renewed for another $3.5 million for 3 years. So yay, good job, Eastern Washington communities. On behalf of various collaboratives, I submitted 5 LOIs because I had nothing to do over the weekend. One around dental mid-levels collaboration, one around health coaching, kind of care coordination, diabetes management collaboration, medication management, and family planning. All of these I helped submit, but will not be leading or doing the work myself. So again, thank you, Eastern Washington.
And thank you for including us, Brian, without our consent.
No. They're non-binding.
We're
non-binding.
We're happy to participate. I'm Lynn Kimball.
It's really easy.
I'm the Director for Aging and Long-Term Care of Eastern Washington and Better Health Together board member. We submitted some LOIs as well and then found out we were in others. So we're, of course, always happy to participate in ways to make the region healthier. We did get a really good federal grant application in for falls prevention for older adults in Spokane County. So we're anxious to hear in August if we can get some more targeted money to help prevent senior falls in our area.
Pam Almeida, Greater Spokane County Meals on Wheels, and we were a supporting organization with OutQ, as well as offering a supporting agency for nutritious meals for a variety of projects.
I am Joy Peltier with Planned Parenthood of Greater Washington and North Idaho. One of our wins is we have 3 pillars of our mission. One is exceptional health care, the second is honest education, and third is fearless advocacy. So in our honest education bucket, we are happy to receive $1 million a year to do teen pregnancy prevention in our communities. We do that in Spokane County, Tri-Cities, Yakima County, and in Okanagan County. We've recently submitted a letter of interest in this ACH, also in Greater Columbia and in North Central, around helping people access reproductive health care. And at our health centers, we also are integrating more primary care, so doing behavioral health assessments and other kinds of integrated care. So we're excited about that.
Hi, I'm Heidi Wilson. I'm a board member for Meals on Wheels in Spokane City. I'm new to the board, so I am still learning how we're all integrating. So.
Good morning, Julie Holmkamp with SNAP, and I have a colleague here that submitted our LOIs, so I'll let her share that news.
I'm Paula Williams from Operation Healthy Family. We were able to submit a mobile dental thing, so we're really excited about collaborating with a lot of you.
My name is Dan Sigler with Pioneer Human Services, and a win for us is that we were recently awarded a contract to start an innovative program at Geiger Correctional Facility that will work with people releasing into the community to follow them for a 6-month period and help connect them with in an innovative way with various services in the community. And we also submitted an LOI for a model for a co-location of housing, treatment, employment training and employment, primary care, and behavioral health.
Scott Davis with the Excelsior Youth Center, and I'm here with Ryan, who will share our big wins.
Yeah, Ryan Kiley with Excelsior Youth Center, and our big win, Scott and I got an email this morning, and it's kind of a micro, kind of ground level big win. Foster kid who aged out of the system at 18, we met a decade ago. He emailed me with his high school graduation picture, and at 23, he walked this last week. Sweet. So yeah, good for him. So planning to be a lawyer and work within the system. So great.
I'm Sarah Bullock-Dorn with United Healthcare, and we recently brought on a housing specialist to help with our Medicaid team. We're really excited to have been on board. We've really, understand that helping our clients with housing and stable employment is a big part of their health.
Good morning, Jerry Allard representing Smile Spokane, and I think our big win from the Smile Spokane is really that we have secured
anchor strategy leads for a local impact network focusing efforts to improve oral health in the region, and a lot of work has gone into that. We're very happy to have those anchor leads on board, and related to that, we have submitted a project LOI to serve as the catalyst for improving oral health in the region, with a particular focus on improving oral health disparities.
Good morning, Tony Smith, Spokane Regional Health District. We submitted several LOIs, but I want to just highlight a couple of wins for us. A year ago in February, our health officer was recruited away by Providence. We have hired a new health officer, Dr. Bob Lutz, who will be starting in the middle of June for us, doing some intermittent work now, so that's really terrific news for us. The other piece I wanted to share is that Helene Dewey, one of the people in our health promotion programs, and myself were awarded a Kresge Foundation grant to work over the next 18 months on issues around health equity.
Good morning, I'm Kathy Olson with Molina Healthcare, and I'm very happy to announce that Molina was one of the chosen MCOs for the North Central region to be one of the apparent winners of that contract. So we're very excited to start that work in North Central.
She stole my thunder because I was going to say the exact same thing. We do. Kayla Down with Coordinated Care, another huge win, great opportunity. We're really excited.
Good morning, I'm Amber Johnson. I'm with SNAP, and a quick win for us is we're working on a grant through Enterprise, NeighborWorks, Robert Wood Johnson Foundation, to do some surveying of residents at our Riverwalk 1 and 2 properties to find out how changing over to a no smoking indoors policy has affected and impacted their health, and also look for opportunities that they're excited about and pursuing to improve their health on site as well. So that's fantastic. We submitted several LOIs, 2 projects, one for Ride to Care, which is an ED diversion program, as well as one for a program called Weatherization Plus Health, which is focused on reducing chronic respiratory illnesses. And then we submitted several partner proposals. We're looking forward to working with you all.
Good morning, everybody. My name is Kat Latte. I'm with Community Health Plan of Washington, and our big win is recently the Healthcare Payment and Learning Action Network, which is a national public-private collaborative focusing on advancing value-based payment, featured Community Health Plan of Washington as one of the committed partners in moving along the value-based payment continuum at a national forum in DC. So it's pretty exciting.
Hi, I'm Mike Weiser with Chaz Health, and I think our big win is getting some capital funding from the state in all the different budgets right now for 3 dental clinics in Spokane, which is really cool. And then we also, like Brian, submitted a bunch of LOIs and for transportation, mental health coordination, school of telehealth, and then just kind of a general one to try to improve on all the preventative metrics like the one question and oral health screenings and so forth. Yeah.
Good morning. My name is Robin Liu. I'm glad to be a guest at your meeting this morning. I am from Portland, Oregon at the Center for Evidence-Based Policy, and I am working with BHT on some technical assistance for this waiver project.
She's crazy smart and a doctor and all sorts of other cool things. That was sort of an under introduction.
I didn't want to take any time.
We're really lucky to have her.
Oh, and I get to follow that. Nice to see you, Robin. I'm Jenny Smith from Newport Hospital and Health Services, and also representing Pondere Health Coalition. And we, as a health coalition, did submit several LOIs and also several partner proposals as well. We're extremely excited as a hospital district to partner with anybody who has projects that we might be able to help with, share data, work together. We have an amazing community in Pondere County, great partnerships with the tribe, and I think we really have an area that's kind of ripe for some new things and some new projects and whatnot. So, and we have a couple new providers that are really geared up and just out of residency and really excited to make an impact.
Good morning, Ron Poplawski, Kalispell Tribe.
very happy on behalf of Jessica as well to have hosted yesterday's gathering of both boards. So I want to thank you for that. And we did submit a letter of interest as well regarding improving access to oral health care in Pend Oreille County by opening up our dental clinic to a lot more Medicaid patients is the goal. And another win is that we have sent our hygienist up to Alaska, Anchorage here just this last couple of days to review the DHAP program. And we're really hopeful that everything will fall into place. And if everything goes according to plan, which you never know, fingers crossed, she might become the second DHAP in the state of Washington.
I'm Allison with Better Health Together, and we're going to talk about all of our wins and excitement.
Hi, I'm Dawn Sayers with Qualis Health. I'm the regional coach connector for this area, and I would say our big win was after a lot of feedback and talking with providers, we were able to develop a financial worksheet for them with plug-and-play numbers and then put office hours together for getting their integrated health team together. That was one of our biggest questions, I guess, is how do we make this financially sustainable, and we were able to put something together, so I'm really excited about sharing that.
I'm Lorene O'Hanlon, Dean of the College of Health Science and Public Health at Eastern Washington, and I'm going to let Donna, my Associate Dean, tell you more, but I just want to say that I've talked to a lot of you about occupational therapy, and I want to say some exciting things. We've got 2 new faculty coming in to that department, so a lot of the ideas and things I want to do with those faculty and students and all of our programs, dental hygiene, we've got to talk about, is that we're getting more people in, which is really good for us being able to move forward as partners with you guys.
I'm Donna Mann. Thanks for leaving all the more exciting stuff to me, although that's really exciting. We are fortunate now to have our big win, most recent big win, is we just opened the Spokane Teaching Health Clinic in collaboration with St. Luke. So what that means for us as a community partner is we now are able to provide clinical services across all of our disciplines, so physical therapy, occupational therapy, speech-language pathology, dental hygiene, and then we also are supporting that with public health and health sciences administration. We really want to be the workforce solution. I'm sad to say we didn't submit an LOI with the academic calendar and all the other things we had going on. I couldn't hit the deadline, so I'm looking forward to when those maybe come around again. But hopefully we can partner up to make some of your projects a reality. The advantage of an academic partner is we need to train our students, and we're working hard to train students that can meet the changing healthcare environment, which has some distinct differences from how we trained students in the past. So partnering up with us gives you an opportunity to bring in a valued service at a high level at little or sometimes even no cost, depending on how we can problem solve that away. We've had a lot of really good successes with community partners with some of our past programs, and we're really excited to sort of vision and realize what healthcare looks like in our communities in the future. And we really also want to focus on rural health. So we are more than receptive to problem-solving ways to getting our students out to rural communities and to building a rural health workforce.
Hi, good morning. I'm Christine Canato with the Healthcare Authority, and Kaylee's going to talk about our big wins.
Hi, Kaylee Klein from HCA. I would just say I had an opportunity to be at an ACH funders workshop last week in Washington, D.C., and it was a good opportunity to reflect on the fact that this is really hard work, but Washington really is a national leader in this area of accountable health. And to be there with a lot of large organizations, federal agencies, other states that were really struggling with what accountable health is. Just wanted to bring that back, that everybody is, the hard work is worth it. A lot of others are looking at the work that you all are doing, and actually just wanted to say thank you for putting Washington on the map for that.
And I'm going to share one big win for BHT is that we have brought on 2 new awesome staff members who are here today. Jenny Slagles in the back, wave. She is a senior, I'm going to get this wrong, a senior tribal ACH program manager in some order like that. So she's helping work with the tribes and ensure collaboration for waiver projects on that end. And then we've also welcomed Devin Wilson, who is another project manager helping out the team. We're really excited to have them.
I'm Lance Laurier. I'm with the YWCA, and I think I'm still learning and observing.
Okay, and just a few more. I'm going to call out some names on the phone so we can hear your big wins. Let's start with Amir. Oops, I muted you all. Never mind, now you're unmuted. Amir, do you have a big win for us?
You're a multitasker.
Going once, still can't hear you. All right, I believe you've done something great. I know that you submitted an awesome LOI on an oral health project, so thanks, Amir. We also have Ali Destatel. Now I'm wondering if we can hear any of you at all. It may be a problem on our end. So I'm going to do some technical troubleshooting and then, what about Kathy?
Can you hear me?
Yes.
Aha, well, this is Kathy with Second Harvest, and thanks, sorry I couldn't be there today. I have another meeting right after, so I couldn't make the time work, so I called in instead. But I think the kind of the big one we're working on right now is just more expansion on our nutrition education outreach. We're making some real moves in that area, and just have a great team on board to do that.
Awesome, thanks, Kathy. And Lindsay.
Hi, this is Lindsay Root-Evivar with Chaz. My colleague Mike Weiser is in the room and he gave our update.
Awesome, thanks, Chaz. Maureen.
Hi,
Maureen from the Washington Dental Service Foundation. Sorry, there's two Maureen's today.
Can you guys hear me?
Yeah.
Great. So, Jerry, our partner with Smile Spokane, gave our big win. So we're really excited about the Local Impact Network.
And Maureen Kate. All right, circling up to Dave Iverson. All right, last try, Jim Jackson, do you have a win for us?
Yeah, this is Jim. Can you hear me?
Yeah.
Yeah, Jim Jackson with DSHS. And we're making some progress on and I'm sorry I wasn't able to be here in person today. I had some other meeting conflicts. And we're making some progress on an organized online strategy for addressing ACH technical assistance needs around opioid response project.
All right, thanks, Jim. And I see that Allie's mic is not working, but her big win is about collaboration. And if there's anyone else who couldn't get through but wants to type their big win into the chat box, I will read it out a little later. Okay, and with that, thank you everyone for sharing some great positivity and excitement going on within our team. I want to share a big win, which is sort of a quick overview on our letters of interest and what we received. So we had the LOI period open from April 1st to May 15th. In total, we got 79 LOIs, which was huge. 47 of those were projects, 32 were requests for partnership. And from that, we had 27 organizations submit project proposals. So a bunch of you submitted multiple, which was awesome. And then some people submitted multiple partnership proposals as well. If we look at the breakdown by county, unsurprisingly, there was definitely a Spokane had the most proposals, and this was the proposals that which counties they said they would serve, not necessarily where the proposals were from. But overall, it was a pretty even spread, I think, for most of the proposals submitted reached out to multiple counties or all counties. So they all have really good potential to spread and scale across the whole region. If we look at the breakdown by project, the most
applied for LOI was Pathways, which we were really excited about. In total, 56% of the proposals included Pathways, even if it wasn't central to community-based care coordination. The LOI said that they wanted to use Pathways as a mechanism to support their project or to be the care coordination element of their project. That was really exciting to us, and also really validating that, you know, this work actually, it's not just in our heads, it actually does make sense as a actionable solution for our community, so thank you all. Second most popular was, well, we had a little bit of a breakdown. So really, we saw that the chronic disease projects probably came the most complementary with Pathways. So there were a lot of people who submitted, they wanted to do like a diabetes prevention with using Pathways for care coordinators. That was really that we got a lot of those, sorry, losing words. And then with diversion interventions, maternal and child health, and oral health, it was all about equal. We had almost the exact same numbers of proposals for those areas. So, but there wasn't any project that was significantly not mentioned. They were all out there. All right, so then I want to just do a quick cover of our next steps for this LOI process. What we're leading up to now is this community showcase event that we're going to host in the second week of June. And originally we were kind of thinking that was going to look more like, you know, we talked about this TED Talk showcase thing where everybody came up and they got 3 to 8 minutes to talk about their project. We didn't know we were going to get 80 projects, and it's probably unreasonable to ask you all to attend and listen to 80 pitches. So right now we're kind of in the midst of thinking about how we want to reshape this event. My commitment to you is that on Monday's a holiday, so on Tuesday, we're going to be sending out an email to everyone who submitted an LOI that has a clarification of the next steps for the showcase event. And additionally, on Thursday, June 1st, we're going to do a webinar that's going to, similar to the LOI webinar I did, it's going to overview the showcase event, what our expectations are and what we're looking for. We're not going to have anything, it's not going to be too prep heavy, so we don't want everyone feeling like they need to freak out beforehand. It's going to be an easy, fun, very like casual way for us to get to know the different projects that you guys are all working on, get to know each other and sort of what you're thinking your role is within this work. And also as a chance for us to start to hear feedback from the community, what you all think about the projects and how they're sounding and how collaboration is shaping up. We're planning to create a scorecard for that event that will ask both Leadership Council members and any public audience members who attend to fill out, as well as board members. And we're going to run those scorecards through that logical decision software that we showed a couple Leadership Council ago that is a computer software system that runs decision-making based on a set of criteria. And we're going to look to make sure that whatever our board answers and whatever the Leadership Council and public answers align. And then if there's any chance that some projects were ranked very differently between the two groups, we're going to go back and have some more conversation about why that happened and what that means. Just as a reminder, this event's going to be on June 14th between 4 to 7 right here at the Philanthropy Center. And it's open to anyone in the public, so anyone's welcome to come and hear about these ideas. We recognize that some of our rural friends probably don't want to drive down. I mean, I hope you want to drive down and spend a fun evening with us. But if you have prior commitments, we understand that. So we're going to send Devin and Justin, our ACH road team, out to do some, basically some videotaping and ask folks to do their quick little pitch by camera, and then we'll bring it back and show that at the event. And ultimately, we'll hope to have all of the videos captured and up on our website too, so if anyone didn't come, they have the opportunity to interface with those. So right now, our team has been going through all of the LOIs, reading through them. There were only a handful, and by handful I mean like less than 10, that either didn't mention metrics or projects in the toolkit, or were a project that we weren't sure how it would fit within this work. In every case, it was a project that could fit and would be really complementary to the projects. However, we're not sure how fundable it is. So in those cases, I've been reaching out personally to try to get some more information and give a sort of another chance to flesh out the LOI.
But other than that, really all of the LOIs looked really solid and really matched well with the expectations that we've been given from the Healthcare Authority and that were laid out in the instructions. So thank you all so much for your really hard work and just giving it your all in this process. We're really excited moving forward. I want to do a quick pause to see if there's any questions. I know this was really fast, and I again encourage you to use the feedback form if you have any longer questions that you want us to post on our website.
And I want to make sure it's super clear, like everybody did such an awesome job, nobody got deselected. Yes. So I think anytime we talk about LOIs, those of us who've been fundraisers our whole life, you sort of worry about the rejection. There was none.
Hadley, will you be able to share this PowerPoint with the dates?
Yes, absolutely. Again, I'll send out the whole PowerPoint and then have a more detailed version to everyone who submitted an LOI.
Hi, this is Kat. So question, does the June 14th Community Showcase take the place of what I believe was the scheduled time of the Leadership Council on the 21st?
Yes, thank you for saying that, because I would have forgot. We are going to cancel our June Leadership Council meeting, and this event is replacing it.
Okay. And then
Once again, we are canceling our June Leadership Council meeting. Thank you so much.
And then the second question is regarding the LOIs. So as people come into the Community Showcase, is there going to be sort of a storming and norming and alignment of those letters of intent, since there might be a lot of alignment regarding how people are applying, and it's not, to your point, a competition. It's actually about really elevating those that are trying to impact the project specifics.
Yeah, that is exactly the point. You put it really well. So our hope for this event is going to be not just that each person stands up and gives this is my LOI, but actually that we're seeing more how it matches. So we're going to be doing another project that we're working right now is sort of bundling up the LOIs to say which ones were in each project category, where there are projects that have a complementary partnership proposal, and we're going to kind of create some batches that will be used at that event to start with sort of a little cohort team. Does that make sense? Okay, awesome. Any other quick questions? All right, if not, there are a few questions on your worksheet, so if you have a moment, feel free to give some more feedback. And with that, I'm handing the mic over to Allison.
Awesome. Okay, we're going to try this again. Me and my friend the clicker. Okay, so we're talking about, so first I want to tell everybody that we submitted our phase 1 certification. Yeah, it was like 106 pages and lots of word limits, so trying to describe a 3-chamber leadership structure in 1,500 words turns out really, really hard and required a lot of creative writing to get the essence of what we're trying to do. But it felt like a big, giant check mark in the big to-do list for this year. So I think that was what we wanted to say there. Okay, so we're going to do 2 things here. I'm going to just briefly talk about this, and then our group activity is going to be around this, but I think there's some other context around the money that is important. So if you remember last month, we talked about the toolkit and the populations, and one of the things that I think we have been thinking a lot about is what is really this theory of change, theory of action that we are trying to do, both with the waiver and with the ACH, and probably most importantly as we think about community health. And we had a bit of an epiphany that we've sort of been thinking about this work chunked because it's sort of easier to wrap your head around. There's the social determinant of health system, and then there's all this stuff about making people healthy in the healthcare system, but we didn't have quite a picture of how that connects together. And for those of you who have been playing along over the last couple of years, if you remember back a year and a half or so ago, we did these idealized design sessions around the priority areas and so forth. And what kept coming up as we were trying to talk about how do we address these core issues was the need to coordinate the coordinators. And in what will now be sort of the benchmark moment, I think, for BHT, we started to really identify what that connection point between healthcare and social determinants. It took us, basically a year and a half to be able to think about this in a two-system piece with care coordination being that link between. So as part of our certification, we had to actually commit to what our theory of action was. So on the slide, you see several different things that I want to highlight. So first off is that we won't get to community health until we have a fully integrated whole person care system, a fully integrated social determinant of health system, and a way for all of that to work both directionally, bidirectionally, I think is our fancy word that we use now, where there is, and in some ways, if I had the skills to be able to make that look more three-dimensional, it's actually not linear, it's much more whole in that way. We have been thinking about the project toolkit, and so you can see up here in the light blue, those actually reflect waiver-funded potential projects in that way. What you will note is the social determinants of health are not funded by the waiver, but what we have identified through our 2.5 years of work is if we could address those 5 social determinants of health, our ability to actually hit whole person health, community level health improvement will be significantly greater. There are clearly a lot of other social determinant of health issues to be addressed, but in thinking about can we make movement on these things, those were a high level. So this is sort of the system piece of it. Adding to that is this idea that we have to shift into paying for value. So we've been talking a lot about this movement from fee-for-service to value-based payments. The ability to do that is going to be partially driven by you have to have a system that actually works this way. There's not a person out there who would say, I would take the risk for making somebody healthy if these systems don't work in a very interconnected way, because you'd never be able to be financially sustainable. And we know you can't really get to being able to measure population health level that takes into all of these elements into account without really robust data management. And so if we look around the community, all of us are probably exhausted by how much measurement we've done, and yet there's very little ability to share that data in a whole model like this. So we then spend a majority of our time talking about how the data sucks, instead of how do we actually hotspot and be able to move the work around. So we see you can't actually ever get to paying for value until you have the system set up and appropriate data mechanisms in place. If anybody's watched the news lately, all of the strides that we made in the Medicaid arena is a little under fire. So we think predicated on our ability to do this is that we continue to have equitable access to care. And step 1 of that is making sure people actually have health insurance. So we have really thought a lot about that. And we are the first to say having health insurance doesn't actually make you healthy if you can't actually get in to see a provider. So we know that in our region that we have a shortage in almost every element of provider capacity. So when we think about equitable access to care, first and foremost is making sure people have health insurance, so there's actually a financial model to be able to provide the care, and continued workforce to be able to deliver that. The other sort of core piece here, and I think we didn't quite see how important this was when we first started on this ACH adventure, and I see it probably more clearly and more importantly now than when we started building out these community-based population health and
social determinant of health strategy maps. I'll sort of look to Tony at this because I remember this being sort of a pivotal moment. Is we have these 5 priority areas, which we all agree are really the priority areas, but being obsessed with priorities and losing sight of what is good policy and system development will mean, yes, you focused over here, but you've lost sight over here. And I think the work we did specifically on the population health strategy maps really show us we can't, what's the analogy, let our foot off the gas on thinking about things like immunizations and smoking cessation and some of these broad public policy issues while we obsess about getting to integrated care and connecting people to social determinants of health. And it's where the magic, I think, of the ACH, not the waiver, but the magic of the ACH actually links up, which is how are we facilitating this system work that is outside our very particular Medicaid waiver population-focused efforts. Additionally, I think when we go back up to our model up here, you start to see an even more important role for the policies and the metrics we're trying to meet on the social determinants of health. It's not appropriate for Medicaid to be paying for social determinants of health. It's very appropriate for HUD to be paying for that. It's very appropriate for our local tax dollars to be doing that. And if we can start to weave those dollars together in a more effective manner, then one, I think we start to get more return on our overall community investment. But two, I think we're going to find that because this whole person care model will not make population health happen without this, we start to be able to push on some of these policy issues that are going to be necessary to actually meet our equitable access to goal and our paying for value piece of this. So you can start to see how we're connecting these dots together. And I think when I look around this room, there's not one person in here that doesn't at their gut level get how this is all interconnected. And the hard work, I would say over the next several months, optimistically, and years, realistically, is how do we hold the complexity of this system with a real intensive, we're going to keep moving through this process portion. Okay, I'm going to pause there and see if there are any questions or comments on that, and then I'll go to this bottom section.
I would make one brief comment about your statement that Medicaid shouldn't be paying for social determinants of health. I would argue they should. I understand they don't. But if you want to know what contributes to your health, there they are. Education, housing, income, food, things we all understand. And if Medicaid paid for that, it would save money downstream.
Yeah, agreed.
So,
fair enough.
Other comments or questions? Support that because I think that's part of the core. If we're not saying that, we're missing a basic message, and that is at the heart of healthcare reform and the impetus for all of this work, right? And so we need mechanisms that enable us to do those activities. That's what's been missing in fee-for-service, right? And that's
The foundation of value-based care. And there's a practical matter that there are other funders who are charged with funding that. And I think the responsibility starts to be at a community level. Yes, let's keep pushing on that concept, but it's going to be up to us to figure out how to braid that. I don't see the federal government shifting in that way. So here's our opportunity as a community until we elect new people.
And I would say another thing that's missing is race equity in this, because in our community, in the social determinants of health, that is something that comes up a lot. Not only your zip code, but also race and ethnicity.
So this is great. I'm a visual, so this is really helpful. Thank you. Can you just touch quickly on the diversion and transition pieces? Everything else seems very clear to me.
Yes, absolutely. So I think built into the system transformation that we're talking about right now is really this idea that your primary care, your pediatrician, or your family practice team is going to be the quarterback for your health. And that if we can start to build a system that addresses your needs at that level, then there will always be a need for diversion and transition because that's necessary, but that doesn't fit in the new model. It's more of a mechanism connecting back and forth. We were trying to really note, this is the healthcare system. This feels somewhere between the healthcare system and community-based care coordination. And then over here we have our traditional social determinant of health. So we may not have quite captured it. You're going to get a chance to talk a little bit more. We're super open to some additional feedback. It just, as we were starting to talk about moving these outcomes, so these are a number of the outcomes that are listed in the waiver and that we've identified as a community as being really important, it felt more practical to be separating out, here's the reforms or the transformation that needs to happen in the healthcare system, in this community care coordination piece, and then continued work on the social determinant of health side of things. Because the next phase of work, we're finally going to move from the 30,000 foot level here to how are we actually building whole person care at a healthcare provider model. And some places will provide the whole circle. Other places will have a network of partners that are supporting that. So this is really that precursor to very intensive, actually operationalizing transformation.
I also am a very visual understander, learner, and so this is helpful. I think getting back to your point, pardon, what's your name? Donna's point, is figuring out how, while we are continuing to push the change in the integrated whole person care system, how we're constantly pushing, and I'm not saying that this is not being said, the recognition of how if changes are happening and costs are potentially being saved or people are becoming healthier, how are you ensuring that the recognition of housing and education and food security and transportation and jobs are immediately sort of thought of? And I think that needs to be, again, not that it's being said that it's not, but I think needs to be immediately recognized with that left side piece, so that as changes are happening in the acute care and specialty, that people are thinking of how, say, in 2 years down the road, can housing potentially be accommodated for if you have flexibility within that payment. And then the other piece is trying to figure out how, with respect to the community-based care coordination, we can start to recognize where place-based health is coming into play. And so the idea of when housing has primary care on site or education has a school-based health center, so just sort of how that already is starting to interplay with leveraging place-based health.
I so need a three-dimensional, I think it's toothpicks and gumdrops and.
I so appreciate those comments, and I don't know whether you want to potentially share something here or individually. Look at a TED video from Anthony Aiton. He is a former health officer out of Alameda County in California. He grew up in Montreal and compares the environment that he had as a child to where he then subsequently worked, and I don't want to ruin his TED video, but it talks exactly about this linkage and what they are doing. He's now with the California Endowment. It's about a 17-minute video and would be terrific, I think, to share maybe jointly at some point.
You bet.
I will find that and attach it to the notes that we send out after this meeting. Anybody else?
I'm kind of a visual and a wrap-it-up person. So I just want to wonder, I really appreciate this first step, and I think I understand that it's sort of the beginning of, as Lorraine was saying to me, interfacing the old with the new. So is it fair to say that this is kind of a dynamic thing. As this progresses forward, then this model also will morph and have more of the three-dimensional feel that you're talking about, so that we bring in these foundational pieces of what's really transforming healthcare in a more intentional way as we have influence on the system. Is that a fair assessment?
I don't know that I have the money to make a three-dimensional model.
Well, regardless of the money, you still have to have the vision, right?
Right. This is probably a fair, without putting partners' names on things, of the model. And yes, in 5 years, we expect that to look significantly different. And we were trying to have a fairly simple graphic that is showing there is healthcare system reform. There is a high need for how does the community portion of this intersect, and we need a more robust, connected social determinant of health system.
Thank you for that. So I would think a council like this, then, one of our roles is to have that broader vision, sort of the 5-year vision, and insert it into the conversation while we have to still be at this more pragmatic first step sort of place, so that we don't lose that broader piece, because healthcare is in a transformation. And so we want to be very mindful of being part of how that transformation plays out, right?
Great comments, Donna.
Okay, so over here, with a whole bunch of TBD, because we don't believe we actually have robust data management systems, are the outcomes or some beginning point of what we have decided as our region are outcomes, and they generally kind of connect with some of the Medicaid waiver outcomes. Last month we spent some time talking about target populations, and I think one of the things that will be both frustrating for some and encouraging for others is as we start to move into how are we going to actually do this work, not conceptually, but very specifically, looking at some target populations where we can both meet the population health level of Medicaid outcomes in order for the region to earn the maximum amount of dollars through the waiver, and the ability to start to create those multi-sector savings that would actually allow for some shifting of investment to occur. So I am all for all of our political advocacy to get Medicaid to change. And I might be slightly cynical because I read a little too much newspaper right now, that we are going to have to negotiate in different ways because we aren't going to see a shift from the federal government on what Medicaid can pay for in the short term. And so when we look at some of these populations, the ability to show those multi-sector savings and negotiate for how those savings get invested more appropriately over here on the social determinants of health is very, very important. And so I think, you know, there's probably not anything in these 5 populations where people would be like, no, I don't think we should worry about the kids, or no, I really don't think all those folks with chronic conditions is a focus. So there is definitely some amount of looking at the metrics that the Healthcare Authority has negotiated with CMS that we're going to have to move, that is reflected here, as well as what we see playing out through 2.5 years of community engagement efforts around transforming health. So we are not at a point where we are saying, if your desired population is not listed here, you're out of luck. This is just more, as we think about operationalizing this planning, how do we help people have some focus so that this isn't the boiling the ocean feeling? And, you know, there's a lot of negotiation that happens as a region as we move through this.
And I would say that's probably one of my biggest questions at this point is I don't know about anybody else, but I know our LOI was fairly
general in overall terms. We were more specific with metrics and, and how we were going to get that done. But at what point do we find out if our projects might align with someone else's and we'd be better, more effective aligning with somebody else to, meet those goals rather than trying to spin our wheels? And at what point do we need to provide more details about our plans moving forward beyond measures?
Indeed. I wish I had a super succinct answer for you. I will tell you what I know is that on June 5th-ish, the Healthcare Authority will release the project templates that we will have to submit on October 23rd. And I've not seen a draft or anything, and Kaylee promises me that they're working super hard as fast as they possibly can. So we feel fairly confident that we'll be able to release that, which will give some structure to this next phase of sort of discussion. I think from the initial point of thinking about this optional project LOI and how we are trying to embrace this idea of the best health answers are as localized as possible into the work. That the LOI, we should have called it something totally different. Like we should have called it the community inventory or something more in, our goal is to take all of the toolkit projects across all of our partners and figure out how to earn the most amount of money. This is not BHT saying to SNAP, you're good enough here, but not really good enough here. This is, wow, this is awesome. How can we make sure that Rural Resources is doing all of this as well? How do we take what Pend Oreille is saying would really work and go to Lincoln and say, probably not exactly the same, but can we ensure this set of population impact can occur, and how do we make the local flavor play out? So as the warning, I think the summer is going to be super intense in trying to move from this high-level project idea, of which I would say maybe 6 weeks ago we sort of had the this is more of an inventory. We need to see where there is community energy, because what we know won't work is Allison telling you what you should do. It's got to align with your business strategies, your mission, and this work that we've been doing to really create a collaborative effort to actually move things along. So I am envisioning, once we see that template, that it will look more like, how does Pend Oreille build out its full system? And it will be obvious where those projects fit into it, and it's where I feel completely confident that what you put forth already fits, because it isn't as if you aren't working in a collaborative manner, which is where, this shifting to how are we building the community collaborative here becomes different than I have the answers that I will tell you when you guess right what they are, and that we'll spend a couple of months trying to get sort of these individualized health systems or health system built out, and then we'll come together as a region to make sure we've actually built a portfolio of projects that ensure you can actually hit these metrics. So it's not going to serve the region well if Pend Oreille can hit theirs, but who should we pick on today? County X will not be able to. It's really going to be, how do we ensure everyone can have success? I think that has been probably the biggest missing piece, is when you look around the region, every community has some amazing bright spots happening, but they're happening in these little teeny pieces. And until we get to, here's the system approach to it, you just are lucky if you happen to be in Pend Oreille and at the Christmas tree celebration you get your immunizations done. We got to start moving to, how does this have more of a system approach? And my hope is the work we've done with our rural health coalitions and the continued work through the Leadership Council, we've built enough common vision and trust that we can start to figure out, okay, where are the places we got to lean in? Like, I don't think that really works here, but I'll spend the energy to figure out how do I take that so that we make sure the whole system works together. So it's coming.
Okay, thank you.
Sooner. And then you get to work hard.
Those are the 3 a.m. questions.
Exactly. No, we agree, and part of what spending time on this is trying to have a shared understanding of what we think the transformed community health system looks like, and then we'll merge that in with what the actual required template is for us to submit. Okay. Yes.
So I guess I'm hoping you could confirm my theory of the theory of action in terms of the metrics. Is it true that the Healthcare Authority and CMS probably don't really care about the metrics in the bottom half, like increased rural health capacity, behavioral health capacity? What they care about is those 40 or 50 metrics that they've agreed to, as well as the first, few in terms of lowering overall costs and integrating payments? But we need to
yes
talk
and
about
no.
because
So it is unclear to me at this moment what our baseline data is and sort of the change that's going to be required and what gets prioritized. I will say some of these things down here, there's a penetration rate metric in there, like can they actually get in to see providers? That feels really real. To me, I think you will see these develop, hopefully after the project template comes out, but in the coming, I'm going to say weeks, possibly months, as we get clearer on the long list of metrics that have been identified. Does that answer your question?
I think so, yeah.
And some of this has been our intent to try and marry work we've done over the last 2 years with my politically incorrect. We didn't love the performance measure pieces, so there's been some translation for us here locally of what we think is actually the more important measure, and I suspect in the end we lose to what the whole model is. So I think those will evolve, but for the purposes of submitting this, we wanted it to be clear from a community perspective, that's how we think it should be measured. And that our community strategy maps actually map back to some of these better than some of the particular performance measure coordinating committee recommendation 52, 57, 59 measures.
And I'll just add, there's, Kaylee from the Healthcare Authority, that there's a difference between the measures that are listed that are going to be attached for the demonstration that that are strategically chosen because we can attach them to payment because they have the right specifications, the right measurement periods, things like that, versus some of the measures that are a little bit more untested that we still care about, though. We just didn't want them to be the sort of crux for payment because they may be unstable measures that you don't want to depend on if it turns out that those are not telling the full story. There will still be a very strong evaluation component really underneath sort of those measures that tie to the payment that we will be very interested in and be monitoring, because I think that also factors into the sustainability for really across the state of telling that different story that may not be getting captured in the ones that are tied to payment. So I didn't want it to seem like we don't care about it.
I know you care, but fiscally you care.
And where would we find those measures? Are those identified? Are those the performance measures in the appendix of the toolkit?
So we are doing some shifting of how the measures are reflected, which is why the tool that's out now is still a draft, because this is part of a back and forth that we're having with CMS. But the ones that were currently organized as system-wide were the measures that are better able to be tied to payment versus the project level metrics which were just listed there as sort of those potential. And so you'll see some shift, and I think where we're trying to get to is clearly identifying those that are at some point transitioning to pay for performance, meaning they are attached to payment, versus those that we'll label as monitoring. And then also what we'll clearly define as sort of those other process milestones that are not measures, but they are those activities that are also attached to payment. And then for folks who are interested, there's also a draft evaluation design. I think the words go in different order, but that's also available on our website. And that we submitted to CMS and are still awaiting their feedback, but that is, as I had mentioned, kind of what we'll also be looking at across the entire demonstration of the 3 initiatives, and that includes additional information that we'll be looking at.
Do you have a sense of when those get finalized? Okay, excellent. I just want everybody to be clear, like, I'm not holding out on you. Okay, let's move. Any other final? I have a money slide, so yeah, I thought that in the conversation. Okay, so this is just our quick reminder of the 3 initiatives. I'm not even going to go through them because you've all seen them. And our friend, the toolkit. Okay, so the Healthcare Authority, this is all sort of still subject to CMS final approval, but the fact that they're like on real slides makes me think we're close. So don't take it to the bank, but you can start to live with these numbers. So this shows the project weighting of the dollars for our region and how they could be earned. I would like this not as a matrix, which is how, if any of you have seen the Manat slides, versus as a whole, because I think thinking about this as a whole system versus all of these sub-pieces as if you could have an effect on integrated care without thinking about maternal and child health. So we're going to keep working on how do we create a model that actually works in your brain to say, it's going to take all of these pieces working together. I want to note that part of the reason the theory of action looks the way it does is 32% of our dollars are going to be tied to bidirectional integration, and 22% is going to be tied to community-based care coordination. So if we could nail that, that gets us over halfway there.
Yeah, I do have a quick question on the project weighting. Where did these figures come from? Because they seem to be such a difference than the percentage distribution of LOI projects that were submitted.
Yeah. They came from the Healthcare Authority negotiated by CMS. And I think it is probably, if you thought about this as this is sort of foundational, this is the infrastructure piece, and then you get narrower in terms of population effect, I think you can really start to see where you have the biggest impact on the most amount of population is where we'll direct the most amount of dollars, and as you get narrower in those populations. And because we did not say we're trying to reflect this in our LOI, we wanted the community to tell us where do they have energy. And I think we all remember we're a little disappointed with the oral health stuff to begin with. So it doesn't match up with how deep the need is here and how creative the solutions can be. So I don't think you should take this as anything other than this is the framework with which we are going to excel at. Okay, so I want to be really clear, I feel like I need everybody to nod their head that they're actually hearing me. There is no determination of how we're going to actually allocate the dollars yet. I'm saying if we were super simple and we thought about allocating just based on Medicaid covered lives, because that's how they determined what our total pool was, this is how it would look by county, by year, if we did everything and we excelled in every one of our outcomes so that we made the money, every dollar that we were available to earn. Okay? Is everybody understanding and hearing that? I don't want any calls from people saying, how come Lincoln County doesn't get as much money as Adams? because I will know it is somebody in this room. No, I'm just kidding. But I wanted to sort of give a sense of why the whole system approach is going to be really important so that you could earn the maximum amount of dollars. We are really hopeful that in a very short period of time, we can develop some financial modeling that will show some better return on investment based on individual program models to be able to hit those outcome measurements so that we're making a really smart decision on what our funding policy will be. But I think it was hard to start to have some of these LOI and system transformation conversations without, at least at a hypothetical level, getting a sense of how many dollars were at stake to be earned. I will also note, actually, I think I have a slide. Yes. So I'm going to just talk through how we could earn our dollars. So year one, which is now until the end of December, so not actually that long, this is how we could earn those dollars. So one, meeting the minimum acceptable standards, and you can see those 6 areas for phase 1 certification, of which we feel generally confident we're going to do that. And the Healthcare Authority will send us $1 million. The second is phase 2 certification, which gets significantly more intense, although I feel like I should have Hadley cover her ears because it wasn't like phase 1 wasn't intense. But phase 2 is due August 14th, and the way the Healthcare Authority is describing it to us is phase 1 is tell us what you will do. Phase 2 is prove that you're actually doing it. There's also a added performance categories around data and transformation project planning, which is where you all come in. The third area is, we talked about this last month, the decision by each individual county so that collectively our region moved to fully integrated managed care by 2019 would trigger another $8.7 million investment. I think it's like 3.2 in 18 and the balance in January of 19. And then the third piece is, oh, actually, I want to go back to phase 2. So this triggers an up to $5 million investment, of which they will take our application and score it, which will then tie to how many dollars we're able to earn. So when we start harassing you for data agreements and further letters of intent and a variety of other things, no, the harassment is really so that the region can earn those dollars, not because we're just annoyingly into a huge amount of process in that way. We are getting sort of on a week-by-week basis more guidance on sort of what those benchmarks are going to be required to be able to do. So I just, in my total numbers, it assumes we are 100%.
I just have a question about, say, you know, phase 1, $1 million invested. Where does that $1 million go? Does it go to you, the BHT? Is it in a pot that people draw down?
Excellent, excellent. There's still some policy to be developed on that. I would say the preliminary policy direction that we are headed is that these $2, these certification dollars, will actually come to BHT, and then the board will set governing policy about how those would be invested. We would imagine a bulk of those dollars go out to providers to get them to participate in all of this work. It is not ramping up the BHT back, what do we call it, backbone staff side of it. We have not formalized what that model is going to look like because we're waiting for a little bit more guidance that we think we'll get in the project template.
do we anticipate it being like a value-based payment kind of payment system, or like a partnership MOU stipend, like how?
Yes, I think it will be more on the following with how we would be able to earn those dollars. So in one of the examples in phase 2 certification is letters of support from each of the tribes and Native project that our tribal engagement policy is actually working. So that's just a have you done it or not, and that would increase your score in that way. I imagine that there's a trigger payment much more tied to have you completed the thing that we've agreed that you're gonna complete. I think we're also interested in understanding capacity limitations on our partners that would prevent them from being able to complete what will be a incredibly intensive 3.5-month period while we actually build out these transformation plans in order to submit on October 23rd. So certainly in that $1 million, we've allocated, I think it's about $350,000 that could be used for capacity investment in that way. And as a general rule, we don't think we need more than 10% to run the backbone organization through the 5-year period, sort of at the high end when you're actually looking at some of those numbers. What's not clear to us is how much purchasing of data management systems we're going to have to make, either as a region or individual investment. I would reflect back to that. If we were just allocating dollars based on Medicaid lives, that probably doesn't sufficiently address some of the baseline capacity that's going to be necessary in order to move population health. So I would say we have a ton more understanding of how those dollars can have the greatest return on investment, so that it isn't, well, easy to understand if, Ponderay County gets however many. Yeah. I'm not sure that gets us to system transformation in that way.
So I guess my question is, the certification dollars go to BHT. Do all the dollars, all of the dollars funneled through BHT? Like
the tricky part of this is the BHT board acts as the governing authority for those dollars, absolutely. Technically, they will all sit at a financial executor entity that will allow us not to go to jail because we didn't know how to properly set up some piece of it. So there's a capacity piece there. But from a technical standpoint, the BHT board will set the governing policy for how those earned incentives will be paid out.
And then I have one more question, and then I promise that's the end.
This is so great. I would much rather have questions than me trying to...
questions, Joy. The other question I have is, have we done a survey or inventory of, what is it, electronic medical record systems, EMRs, about what we all use and how we could share data?
Ish. So I would say it's generally insufficient, and both the surveying and that we are fairly confident the systems are incompatible right now.
Okay, thanks.
And I could comment on that the Spokane County Medical Society has an informatics group that has literally worked on this for 20 years. And the transition from 2 not-for-profit hospital systems to the 1 for-profit, 1 not, and now the transition back to 2 not-for-profits has really impacted that. The exciting news is that Providence, Multicare, and Kaiser will all be on Epic. So for smaller clinics and providers to link to systems, it will be much more one system, although they're on different versions at this point. It's a whole lot different than having some on Meditech and some on Epic.
So I have one question about, so the BHT board basically decides whatever, is what group, what are we doing here? What is the Leadership Council? What piece do we play in that? And do we have any say in what that looks like, or do we meet with the board? Yep. And how do we do that if we are committed to doing that? Some of us have been here every single meeting, like myself, and I really I want to make sure that we give our input, particularly from me as a provider, because I look at this and it frustrates me just from not my organization, but as a dental provider. I think we're talking about healthcare, and look at how much is actually going to the providers, and it's hard for us because we can't continue to provide oral health if the oral health providers or the medical providers are not getting this money. So I want to make sure that some of us are on that deciding factor.
Yes, so one of the things that we are instituting is starting in June that there will be a public comment period at the beginning of our sort of pre-board meeting, where it would be a great opportunity for people to come and provide very direct feedback. We have included in every one of our board agendas a feedback loop from this group based on feedback that is being put forth. And as we start to develop out these models, we would fully expect that both as a body here, there would be an opportunity to give feedback, but probably more practically, as we build out these transformation plans, that's where the real pushing of the discussion actually plays out. I think we've done a number of meetings with partners where the CFO is sitting at the table, and the level of questions that get asked in that way really helps do program design in a better way. And so I think we're really committed to a process that allows from the ground up, not just sitting in this room, because I think some of this is so complex, and each business model of the health system, sort of in quotes there, is different, that we will take that type of feedback and synthesize it back. But you certainly, we're going to, I don't know if that was, it will be announced when our next board meeting is in the public comment period that would precede that. I think it's the 15th from 12:30 to 1:30. But that will be well publicized and open for lots of feedback.
That was correct. June 15th from 12:30 to 1:30.
There was a question that came up in your chat box.
Thank you, Robin.
Jerry?
Yep, so I hope I can articulate the thought that's going through my mind, so bear with me, going back to the pie chart, because I know in my former life as a funder, once you start naming it and putting percentages to dollar amounts, people start getting concerned. And correct me if my thinking is wrong on this, but looking at bi-directional integration, community-based care coordination, and probably diversion and transition, those are all systems that we're working to build the foundation for a truly integrated healthcare system, including oral health. And that when you get to, and you need those in place first before you're really going to affect change in the direct delivery, service delivery model. And the other thought going through my head is, around oral health. I'm here for Smile Spokane, seeing the 3%, the first natural reaction is 3%. But when I think about it a little bit more and I challenge myself, you're really not going to affect oral health. You can't think of those in silos, I think is what I'm trying to say.
Precisely.
So oral health and maternal child health, for example, if we are looking or discussing really increasing the amount of oral health screening happening with well child checks or in the OB office, one affects the other. And so it really isn't a siloed approach, but when you put it into a pie chart, you name it, you put numbers to it, I know it's a very natural reaction to have some disappointment. So those are just my thoughts.
Absolutely, absolutely. And I don't think there is anybody in our region who isn't disappointed, both with the models that were reflected in the oral health toolkit and these weightings. The thing that I think was helpful for me to shift that thinking is one, in our model here, the waiver talks about bidirectional integration of behavioral health and physical health. It doesn't even mention oral health in that. But what we're saying is you can't actually get to integrated whole person care without that. So in a lot of ways, the oral health, varnishing teeth in your primary care or your pediatrician's office as a prevention mechanism is really based on what we imagine is going to happen in how we redesign primary care. And that as we're building these transformation projects, that's what we're going to be evaluating is, are you talking about how your system's going to shift to be able to do that? So I had hoped that a circle looked more whole than that, but I will keep working on my graphical piece. I do think that there is probably more policy-centric change that has to happen on oral health in order to radically improve it, and that the waiver is not that mechanism to be able to do it, which when I go back to this over here, this is why this work is so important. You're not going to address everything that needs to be addressed in the Medicaid waiver, period. I think we missold that early on, that it was all things to all things in all ways type of thing. So, if you can kind of bear with us that this is more of a collaborative effort across a bunch of things, and there is going to be a big focus on these elements within the waiver in general. And as a credit to Washington Dental Services Foundation, I think their efforts to make sure there was not one ACH in this state who was not also talking about oral health as a primary driver of making people healthy. This would not have, it would not have been possible. I think in our region we would have, because from my first day here, we've been talking about the oral health crisis, but I don't think you would have even seen it in a toolkit in that way. So there's a lot of credit there. So if we think about progress and a journey, hopefully that helps. Okay. So then this last piece, I just want to note this. So at the end of this, so on October 23rd, we're going to submit our regional project portfolios. They will be scored by an independent assessor. So it doesn't matter how nice we are to the Healthcare Authority. It's going to be scored by an independent assessor, and they will determine of that $15 million how much we have earned based on successful project development, which I think then sort of speaks to how important building out this system is and where we're able to weave in some other investments. So when we talk about the work that's happening around oral health, independent of the waiver, whether it's the Providence Dental Residency Clinic, some of the work WDSF is doing here locally, et cetera, that's not funded by the waiver, but it's going to help us achieve those outcomes. This slide talks about the pay for reporting versus pay for performance. And so you can see, so year one is actually the year we are in. So you submit, some level of evaluation, you get your money or not. Year two, very, very similarly. I had some new information shared with me where this is the plan, this is the implementation plan from that standpoint. And then year three, it starts getting real with 25% of the dollars being able to be earned being based on performance. And so I put over here some of the example metrics that are reflected through there. You should not take that as anything more than just a representation. But you can see by year 5 how large a percent is based on our performance, and how important making sure that we're building out a system that moves us to value-based payments are in the first couple of years, because your ability to earn those dollars in year 4 and 5 are going to be very dependent on that piece. Oh, I thought this sort of goes to what can we spend these dollars on? My favorite part is what we can't spend it on, which is alcohol, entertainment, bad debt, or fundraising. So that just made me giggle. But you can see here just some examples of how we envision these dollars being spent, and the intent to have this be a very collaborative, open process so that nobody is feeling like somewhere in a dark room, Allison and Hadley are deciding who gets the money. Okay. Either we can do this or we can move into...
Yeah, so I think this was a awesome discussion so far, and I want to see if we can move it into some small group discussions to work with the worksheet that we made and just generate some more feedback and any questions that this may have brought up. So the worksheet has questions for all of the sections that we just went through, and my original intent was that we focus on the theory of action questions in the small group discussions. I'll leave it open to each group to sort of go wherever their energy is. My goal would be that we get as many of these feedback sheets returned to us as possible with some good critical thoughts and feedback that we can use as we move forward. I'm going to do this old school and just count off like 1 through 4. And I'm going to say we have 3 board members here and Allison. So I'm going to ask each board member to be a group leader so that you can have an ear on what the Leadership Council is saying. And then Allison, you'll lead the last group or just listen in. You don't have to lead. All right, so Maria, you're number 1. Brian's 2. I'm skipping you 3, 4.
1,
2.
I didn't know. We said 5, so 4. 4. 1.
2.
2.
3.
4.
1.
Don. 2.
3. I don't have any idea. Thank you.
You're 4. 1, 2, 3. And then Jenny and Devin and I will be floaters to help with any questions. If you are on the phone, I'm going to mute the room for you, and I would say that you're welcome to have discussion with the other folks on the phone. You'll still be able to hear them. Otherwise, if you could open up that worksheet, which was in the webinar portal, and start to fill it out and then email it to us, that would be a really great use of this time. I think because it's a little shorter, if this is okay with all of you, I would opt to not have a report out time because you have these sheets that you're going to give to us. So we will be here for questions, comments, anything for the next 20 minutes. And I set you free. Let's say group 1 is going to meet in this area with Lynn. Group 2 is going to be with Pam, who's going to go in this corner. Group 3 with Torney is going to go this corner somewhere. And then group 4 with Allison over here. Thank you all. How many pens for you all?
2. Yes.
you.